Okay, so welcome everybody today. My name's Jenny Fitzharding. I'm one of the volunteers for NEA BPD Australia, and I'm happy to host today. First up, I want to acknowledge that we are all meeting on Aboriginal land, and that we acknowledge NEA BPD acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples present today. So for those of you that are not familiar with NEA BPD, that stands for National Education Alliance for Borderline Personality Disorder. Our primary aim is to support families and carers of people living with a personality disorder, which can affect up to 17% of the population. There are many types of personality disorder, but BPD is one of the most commonly diagnosed. It's a complex diagnosis. It's a complex diagnosis, and it can wreak havoc not only for those living with it, but also for the people around them as well. NEA BPD is a volunteer-run organisation, and we have more than 200 volunteers right across Australia. We're one of 26 countries around the world that offers the Family Connections program. Family Connections is a 12-week evidence-based program that provides skills and hope to family members and carers. The program is offered free of charge to participants and is led by our volunteer leaders who generously give their time to support other families. We receive no government funding whatsoever and rely solely on the generosity of our families and supporters. So as I mentioned before, we'll get you to put your questions into the chat. We'll also add a donation link in the chat for anyone who would like to make a donation. There's no obligation to do that. We understand that when people are dealing with serious health problems, every dollar counts, but we also, for about every $250 we raise allows us to support one family through our 12-week program. Please keep yourself muted during the presentation. We don't want to see you pop up in the video or get distracted. And as we're recording, please turn off your camera if you don't want to be displayed. So with all that said, I'd like to introduce our speaker today. Paul McNeela is a psychologist, a mental health nurse and family therapist, and has been working in mental health since the early 1990s. He has a wealth of experience working with literally thousands of suicidal people in psychiatric hospitals, emergency departments, community mental health teams, adult and children and adolescent mental health services, and in private practice. Paul's going to talk to us today about Thomas Joiner's Interpersonal Theory of Suicide, which is a model that aids the understanding of suicidal behaviour and guides professionals and carers in how to reduce the risk of suicide in their clients or loved ones. Okay, so over to you, Paul.
Thank you very much for that kind introduction, Jenny. And hello from Carnup in Perth, Western Australia, Noongar country. So I'd like to talk to you today about Thomas Joiner's Interpersonal Theory of Suicide, which I have personally used on numerous occasions to guide me in how to work with suicidal clients and their carers. The first slide is basically just a little bit about my experience, and I won't really dwell on that. Only to say really that my first formal experience with suicidal people was working in Scotland in 1992 as a volunteer for the Samaritans. If anyone has lived in the UK, you may know that the Samaritans do the same function as Lifeline, and they do a kind of crisis call centre for suicidal people. Before that, I have got lived experience of family members who are suicidal, so I kind of grew up with it. And as Jenny said, I've been a mental health nurse since the 90s. I've been a counsellor for many years, and I finally finished my qualifications in psychology a few years ago. So I'm currently working in private practice only as a psychologist. The next slide here, I thought it was just worth talking a little bit about the extent of suicide as a problem compared to other causes of death. Sorry, I'm just moving things around so I can see what I'm talking about. And suicide, statistically, according to ABS statistics, is usually the 15th leading cause of death. And when people look at that statistic, they'll think, oh yeah, suicide's a serious problem, but there are many more serious problems other than suicide. However, when you look at the statistics in a little bit more detail, the median age of death of all causes is 82.2 years of age, whereas the median age of death by suicide is 45.6. So if we use another measure rather than just the straight calculation of cause of death and allocating what the cause of death is, if we use years of potential life lost as a measure, YPLL for short. Now, what that measure does is it compares the age of death with average life expectancy. So with the average age of a suicide death being 45.6 compared to all deaths being 82.2, you can see how suicide is higher up in that scale, and it is actually the most prevalent in the years of potential life lost. In that measure, suicide is the most serious cause of death. So I'll just carry on into the next slide. Just wanted to talk about a few more statistics before we get into the theory. This is from ABS statistics 22 to 23. People who have suicidal thoughts during that year were calculated at roughly 645,000. Suicide attempts, 65,000. Actual deaths by suicide, 3,249. Or we could represent it in terms of the number of people per 100,000 of the population. As you can see here, I've pointed out that the people who have suicidal thoughts in any one year, 99.5% of them will not die by suicide. People who have suicide attempts, 95% of them in any one year will not die by suicide. So this makes assessment of suicide risk a rather difficult task, doesn't it? So although it's a very serious problem, as we've shown in the years of life lost measure, it's actually, compared to the people who have suicidal thoughts, death by suicide is comparatively rare. So it's very difficult for us to use our health resources to identify the people that are most at risk. And as I say in the bottom comment there is a science of suicidology, but unfortunately compared to other areas of medical and mental health research, in terms of people who are most likely to die by suicide, we're handicapped by an inability to interview the sufferer. So this graphic here is quite a good way of explaining the Joyner interpersonal theory of suicide. What he says is made up of is suicidal desire and an increased capability for suicide. Suicidal desire has two components. One he calls thwarted belongingness, or you could call it failed belongingness. And the way he describes that is that the need to belong is a very powerful motive for us humans. So when someone feels that they don't belong, if they don't have extensive social networks that they feel like they're a member of, this is when people experience thwarted belongingness, which can be summarized by the statement, I am alone. However, in this theory, the desire for suicide is not made up only of that. It has to be combined with another concept that Joyner has named perceived burdensomeness. The thought that my life is worth more to my family, to my future genes, to society, dead rather than alive. When there are those two concepts very active in someone's mind, this can intersect and this can create the desire for suicide. Now, Thomas Joyner was a clinical psychologist who was an academic in Georgia in the USA. And he was rather shocked to his rocked to his foundations when his own father unexpectedly died of suicide. So he then devoted a lot of his career into researching how we can better target resources at people that are at most risk of actually dying by suicide. And when he started doing his research, he realized that there actually wasn't very much by the way of reliable predictive tools or questionnaires or risk assessments that would actually accurately predict who was most at risk. And therefore, the difficulty is, where do you then direct resources? So he then did all this research, and he came up with this problem that you can't actually interview that 0.5% of people with suicidal thoughts who actually die by suicide because they're already dead. So what he did was the next best thing, and he did what he called psychological autopsies. So what that consisted of was analysing suicide letters, suicide notes of people who had died by suicide, and also interviewing friends, families, and carers of victims who had died by suicide. And then basically doing a kind of qualitative analysis and looking at the themes. And that's how he came up with these two concepts of thwarted belongingness and perceived burdensomeness, because this came up again and again and again in the suicide notes of people who died by suicide and interviews of the people close to them about what their mental state, what their thinking style was prior to the suicidal event. But the other aspect of Joyner's theory is this acquired capability for suicide. So people can have that thwarted belongingness and that perceived burdensomeness, which combined gives a desire for suicide. They can have suicidal thoughts, but in this theory, they remain suicidal, but they do not die by suicide unless they have this other component of acquired capability for suicide. What is this acquired capability? So Joyner pointed out that it is against so many of our instincts of self-preservation, perhaps caring for others, perhaps passing on our genes, all these primal instincts we have that mitigate against someone taking their own life. So for someone to actually have the desire for suicide and then to plan and actually implement the plan, in this theory, they need to have an acquired capability for suicide. And how they acquire that capability is by exposure to pain, death, suffering. The more people are exposed to pain, death, suffering, self-harming, suicide attempts, every time they're exposed to something like that, it ratchets up that acquired capability for suicide a couple of notches. So even us here today talking about this theory, we are to some degree increasing our acquired capability for suicide ourselves, because we're actually talking about it to a degree. Yeah, not to say we shouldn't talk about it, But it's part of that increased capability. And Joyner used this theory to explain why there are certain occupations that have higher suicide rates. Occupations like defence personnel, police officers, doctors and nurses who work in emergency departments and intensive care units, vets, veterinary nurses. And also I can explain why people who are exposed to certain types of trauma, or perhaps even all types of trauma, have got higher levels of suicide than the general population. So if someone's a domestic violence victim, a victim of child sexual abuse, physical abuse as a child, bullying at school, these individuals experience habituation to pain and suffering. So it becomes actually more tenable, more palatable, more logical for them to contemplate ending their life as a solution to their problems. So anyway, I think I've given a decent explanation of these three concepts. Happy to answer more questions on these later. But then the theory then goes on to postulate that where there is that intersection between the desire for suicide and the capability for suicide, and you see that arrow coming down to lethal or near lethal suicide attempts, it's Joyner's proposition that most, if not all, suicides come in that part of the Venn diagram where it's intersected by all three. I'm just going to go on to another slide that just shows a different way of explaining that. Everyone's got different learning styles, and this might just, now that you know a little bit about the theory, this might just make it a little bit more clear. So if we have the thwarted belongingness, I am alone, the perceived burdensomeness, I'm a burden, and the acquired capability to suicide, I am not afraid of death, I can kill myself, then when those factors all combine, this is when people are at a very high risk of death by suicide. So I guess what we're interested in is how this theory helps us, because it's my firm belief whenever I've worked in mental health professions, the only point in a theory, the only validity in a theory, the only value in a theory is if it actually helps us in our practice. And in this case, the practice of reducing suicidal risk in individuals. So what I like about the Joyner theory is when I've been working in emergency departments or community mental health teams and talking to concerned family, relatives, carers, what can we do? What can we do to reduce the risk to our loved one? And I think one of the questions here is what resources or approaches may be most helpful if there's a high suicide risk. What I find is if I explain this theory to families, now in this theory, when someone has got an acquired capability for suicide, that is kind of fixed for life. So it's only over the long term that that acquired capability can be reduced. So if we're dealing with the suicidal person in the current scenario, we've got to accept that this is the level of the required capability for suicide. We're not going to be able to reverse that quickly. So what we can work on is the suicidal desire. These unhelpful thinking styles, I am a burden, I am alone. This is what carers and spouses and partners can do for the person at risk of suicide. We can actually help them to refute those unhelpful thinking styles by reassuring them that they are not alone, that there are people in their lives that are happy to support them. Reassure them that their life is not worth more dead than alive. Their life is not burdensome. In fact, their suicide would be far more burdensome to their loved ones than them continuing to live. Of course, people with suicide often are suffering from depression, anxiety, BPD, and that results in those of us who suffer from those conditions having a very negative mental filter. We overprivilege all the negative information in our environment to support these negative beliefs. I'm a burden, I'm alone. So I say to families, you need to tell your loved one that they are loved, they are supported, you're happy to support them, they're not burdensome, they are actually a big part of your lives, they contribute to your lives, they make your lives richer. So this is what we can do. We can attack the suicidal desire, because the acquired capability of suicide on its own will not result in a death by suicide without the suicidal desire. So when people have got high acquired capability for suicide, that's what we need to work on, the suicidal desire. And the hope is that over time, if they can reduce their exposure to death, pain, suffering, if they can reduce their self-harming behaviour, the seriousness of their suicidal thoughts, over time you can reduce that acquired capability for suicide. Perhaps if someone's in a high-risk occupation, they should think about changing jobs, so they don't have that exposure that is constantly leading to their increased acquired capability for suicide. I just did a slide here of a few things that I've found in my experience that do help when we're working with suicidal people. The one in the top left as we look. I used to work in emergency departments where working with the specialist emergency department nurses and doctors who are accustomed to dealing with fractured bones of children coming in from footy or basketball training, motor vehicle accidents, acute exacerbations of chronic illness. That's what they're comfortable working with. On many occasions, I encountered frustration and hostility voiced towards mental health crisis presentations, which was invariably suicidal presentations from these ED doctors and nurses. What I found helped them to explain why someone would take an overdose and then 20 minutes later phone for an ambulance. They're not time wasters, they're not malingerers, they're not frequent flyers. What I would explain to my colleagues in the emergency department was that they've got this internal battle between the part of them that wants to die on the one hand and the part of them that wants to live on the other hand. And in a suicidal person, the strength of each of these extremes fluctuates. So we could say that when the person took the overdose, they perhaps 95, 99, 100% wanted to die. Then they contemplate things afterwards. The suicidal desire decreases. Perhaps they feel they are not alone. Perhaps they feel they're not a burden. And the desire to live increases. So that's when they phone for the ambulance. And I find also that's a good way of helping carers and relatives who are supporting a suicidal person to think that as a whole, this person is not suicidal, but they have this internal battle going on between the part of them that wants to die and the part of them that wants to live. Again, moving on to the middle, presenting suicidality as a mediated part of the self, brought on by stress or circumstances. It's not a fixed state. If we can convince the suicidal person of that, it helps them to realize, oh, when my wish to die is a high percentage, this will pass. The wish to live will increase again. Yeah. I'm not sure how many clinicians are here, but the rating questions is probably more for kind of therapeutic interventions rather than working with loved ones. And yeah, I do explain the joiner theory, as I've explained to you, how it all fits together. And it does give carers and relatives a feeling of positivity, or here's something we can actually do to reduce the risk of suicide in our loved ones. Like Meditations, Marcus Aurelius, Man's Search for Meaning, Viktor Frankl. These are books sometimes I recommend to suicidal people to read that gives them another perspective on their own experience. Another thing I think that really helps is if the suicidal person can have a therapeutic relationship based on those qualities that I've outlined. Someone in their life that can explore with them their suicidal desire, as well as their loved ones, because the conversations we have with a counsellor, therapist, psychologist, mental health support worker, whoever that person is, are different from the conversations we have with our loved ones. When my clients come to see me, I'm an important person in their life temporarily for a certain period of time in the week or in the fortnight or in the 3 or 4 weeks. So they know they can actually share things with me without it potentially having a long-lasting, devastating impact on the relationship with their loved ones forever. They can share things with me on a confidential basis and perhaps explore some themes in their life that through protecting their loved ones, they don't want to expose them to. So I think it's very important if someone's suicidal that they have that strong therapeutic relationship with someone outside their support circle. I think I've talked enough, and I think I'd like to open up now and hand back to Jenny for any comments or questions that there might be.
Yeah, look, thanks so much for that, Paul. You know, I asked you to come because I went to a presentation by you as a clinician, and I thought, oh, this could be so empowering for carers to know that, you know, here are some practical things that you can do to help sort of reduce that thinking in the time, and also you know, I think just getting emergency clinicians and that educated around there are parts of people that want to die and there are parts that want to stay alive, and let's engage with that part that wants to stay alive in the crisis point. So yeah, I found that you know, great to go through that model again. So we did have some we have had some questions come through. One of the more recent ones was, how does suicidal ideation and intrusive thoughts starting in teenage years pertain to this theory?
Okay. Well, I guess how it would link with this theory, Jenny, and everyone listening, is it's going back to these two constituent elements of the suicidal desire in Joiner's theory. The thwarted belongingness or the lost belongingness. So the teenager doesn't feel that they belong very strongly in any group. As we know, the teenage years are a crucial period for developing our own identity and sense of self. And it's a period where individuals congregate together in groups. They identify with groups or types of, in terms of fashion or musical tastes or gaming tastes. So it's a very important period in our lives, and where that need to belong is perhaps at its height. So yeah, so I think that would be quite critical with a teenager who's developing suicidal ideation. So the task there would be, in my opinion, pertaining to this theory, to help them feel like they belong, maybe to assist them to join some social groups that they're interested in, so they do have that sense of belonging. So yeah, does that answer the question?
Yeah, I think the other thing, I might ask you to just stop sharing your presentation so that
Okay.
people can see your lovely face more.
Let me see if I can work that
Yeah,
out.
and I guess my other comment would be sometimes, it can relate to maybe something has happened at school or that they haven't disclosed, being curious about a change within a change within, there we go. Yeah, there might have been some kind of a change within their friendship group, or
Yeah, true, yeah.
having a change of teacher who is more harsh, or it can be stuff that's not necessarily big as well, can't it? That can.
Yeah. They might be going through some experiences where they're feeling burdensome towards their parents, their family,
Yeah.
or siblings or friends, feeling that they're not contributing, that they're a burden.
Yeah. Okay, and another question that we had, so what, I guess they're talking about a safety plan here. So what do you recommend to be included in a safety plan to help consistent response from helplines, emergency services, ED and treating teams where there is repeated suicidal ideation and behaviour? So I
What would
guess, I mean, what's happened in your experience with, do you find that you get treating teams taking different approaches that are sometimes cancelling each other out, or
I guess I find with a lot of families that present to emergency departments, if they've got a suicidal person in their family and they present on several occasions, quite often these families find the initial response from the emergency department to be quite inadequate. And I guess the default advice is lock up your knives, lock up your pills. If you feel reassured, ask the suicidal person to leave their bedroom door open when they're asleep, sleep in the same room as the suicidal person. I guess these are like the default. This is the default advice when we don't have a bed for someone who's presented to the emergency department and we're sending them home with their family. And often I found that that was inadequate. And I guess it was experiences like that, Jenny and everyone, that made me look into some suicidology theories to see what more we could actually offer. And often I would actually explain this joiner theory to families in the emergency departments. And it assisted them in thinking they had some agency and they could have some positive effect on supporting their suicidal loved one in their family. So I guess what would I recommend? I would recommend explaining the joiner theory to families who present with suicidal individuals.
Right. Yeah, we've had a couple of comments saying that they really appreciate, you explaining it so clearly and having this kind of roadmap. Do you find, so we've had a few questions around autism, like is there, sorry, the way the questions come through, it's not showing me the whole thing.
I can read it here, Jenny.
Yeah.
Advice for a young 26-year-old autistic patient who is stuck in suicidal attempts for the past 5 years, now locked up for her protection under NDIS. For autistic people, is there a different approach, or has there been any studies looking at people diagnosed with autism and their suicide attempts? I must admit, I've not trawled through a lot of research regarding autistic people who are suicidal, but I have worked with a lot of autistic people who are suicidal. And of course, I am aware that with any diagnostic label, you can't just overgeneralize. I've got a son with a diagnosis of autism, and I've worked with many clients who are autistic, and I find them all to be unique individuals. One common factor, however, I find with people with a diagnosis of autism is a tendency to exhibit quite a lot of black and white thinking. And this is particularly dangerous when they're going through an episode of having suicidal ideation or suicidal desire, because they've got black and white thinking. Sometimes they're more logical than emotional, and they very quickly acquire that capacity through their own thinking styles and feeling styles to become risky of actually dying by suicide. So I would refer back to the concept of parts of self, the part of us that is suicidal, the part of us that wants to live, and impress on the autistic person themselves, hey, this is just a period that will pass. The part of you that's suicidal will at some stage decline. The part of you wants to live will increase again. When that happens, you will be very pleased that you're not dead.
Yeah. You will be. Yeah, future you is going to thank you.
Yes, absolutely.
Yeah.
That would, you know, depending, of course, on the level of function of the autistic person, you would have to tailor your description accordingly. Yeah.
Yeah. Or even, I mean, but that's true of someone who's not autistic, who's incredibly emotionally dysregulated. You know, the concept of future you is completely offline.
Alien. Yeah.
So,
yeah.
so, you know, sometimes it is about,
It's right in the forefront what's happening now. Yeah.
Yeah, exactly. So all of this is about responding in the moment. Yeah, and I was actually, I'm really glad that Amanda in the comments has made a comment about finding it helpful to talk openly about this topic with their loved one, to normalize the feelings as part of a continuum of human experiences rather than pathologize them. And yes, that is parts theory. And I did, when you were talking about that exposure to, you know, to death and trauma and suffering, increasing our capacity to consider suicide, is balanced by that need to not, because if you don't talk about it, you're reinforcing the I'm alone.
Absolutely, yeah. Again, often in the emergency department, I'd speak to, I worked in the Children's Hospital in Perth. So it was under 16s would be brought in by their family. They might just say the S word, and the family are in panic and don't know what to do. So they think, oh, take them to the emergency department. They're the experts. And then they would see perhaps a triage nurse or an admitting doctor who are, you know, the type of emergency clinicians I described earlier on. They don't speak to them about suicide. So their parents haven't spoken to them about suicide. The admitting doctor hasn't spoken to them about suicide. Then they get referred to the psychiatric liaison nurse. Well, that's what we're called in WA anyway. And then we're the first people to talk to them about suicide. And you actually find often that although they're presenting in an emergency, their level of suicidal ideation is not terribly risky. It's maybe just kind of mild to moderate risk. And it's treated by just having a conversation, like you say, Jenny, and like your contributor commented, just normalizing the process and the fluctuating nature of the desire to suicide. And often, and I guess it's equipping those parents with the ability to do that themselves the next time.
Yeah.
Rather than going through the rather traumatic experience of an ED presentation for mental health reasons.
Yeah, because it can inadvertently reinforce if you can't get attention.
Yeah, that perceived burdensomeness. Yeah.
Yeah, exactly. So Tony has commented that it sounds like from what you're saying that effective relationship mindfulness, which is a term that we use in the family connections course around DBT, that we're not just mindful of ourselves and our environment, but we are mindful of our relationship, that we bear in mind that, like if someone's really getting up our nose and really irritating us, we bear in mind that this is still somebody that we love and who is important to us, and all the rest of it. So he's saying that, from effective relationship mindfulness and empathy can significantly reduce risk. Is this correct? That having that
I would agree.
relationship mindfulness and empathy, just
I would absolutely agree with that. Yeah.
yeah.
The more we can be aware of our, the processes behind our thoughts and feelings,
Yeah.
the more, I guess, the more mastery we can have over them.
Yeah. And going with the parts thing, I often will ask clients, what is it that you want to kill off?
That's a good one.
Because let's not throw out the baby with the bathwater,
Yeah. 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 So it's this problem that's the problem. You're not the problem.
Yeah, I wouldn't want to keep living like that either, like being with someone. And so how do we fix that? Yeah. Also, there's another question from Kaz. Is there any research or statistically relevant relationship between higher suicide attempts and people expressing themselves from violent patterns of behaviour? For example, after an incident of domestic violence.
Yes.
Mm-hmm.
Look, this is the book by Joyner. There's about 200 pages in here. Interpersonal Theory of Suicide by Thomas Joyner. So I've just given a quick summary of the theory, but he goes into detail about how that acquired capability for suicide is linked to the experience of domestic violence and all forms of trauma. Even when he talks about the acquired capability, he first of all, he talks about it's difficult to kill yourself, but it's also difficult to kill someone else. And he describes a lot of statistics from warfare and battle, where I think the more kind of 19th century type of warfare, where they have statistics for bullets used and casualties on the other side. And they came to the conclusion that often soldiers are aiming above the heads of their enemies.
Yeah. Well, that's why you need 12 people to kill a man in a firing squad, because only one bullet will hit.
Absolutely. Yeah.
Yeah.
So that natural instinct resistance we've got to inflicting death on others also applies to ourselves. But if someone is a domestic violence victim, chronically, repeatedly, they're going to have that exposure to violence, pain, suffering. They're going to feel worthless. They're going to feel burdensome. So yeah, of course, there's a heightened risk for someone who's experienced domestic violence.
Yeah. I think the question might also have been the other way, if the person is the perpetrator of the violence, and I would wonder if I'm not aware of any research, so I'm just
I'm not either
here, but I think that the shame, if it was a kind of a rage attack. So I have to say, I've got two adolescent butcher birds and their mother right outside my window, and the kids are complaining like crazy, and the mother's going off, and I don't know if it can be heard on Zoom or not.
No, we can't hear it.
Oh, good, because it's really distracting.
Okay.
Thanks
for that little insight to your world.
Yeah. Oh, they're divine. I love them, but they're really annoying. But what I was going to say is that if someone has lost control of their behavior, they have behaved in a way as a result of their rage that doesn't align with their core values, then they may go into a shame spiral. And I would imagine that shame is quite a dangerous emotion when it comes to suicide.
Yeah, absolutely. And I don't know about the research, but I do know this theory quite well. And Joyner would say, yes, perpetrators are more at risk as well. Because they've had that exposure to violence too. Inflicting it, not receiving it.
Yeah. And they may well experience shame afterwards.
Yeah, absolutely.
Yeah. And I think there was another question. Amanda's made a comment about, I guess, the balance of the black and white thinking of autism is also the greater pattern recognition. You know, everything's
Absolutely. Yeah.
balanced, and
Yeah.
in that it means that you know, you can recognize that life can be terrible and unjust, and that great dialectical, and you know, it can also be full of people who are kind and beautiful and life things that are
Absolutely. And
beautiful and
I did
meaningful.
see I did see Amanda's message flashing up, but then I couldn't find it because there's a lot of things
Yeah.
coming through. But I think she also mentioned pointing out that people with autism can have very high IQs, and I completely concur with that. And I hope my comments didn't imply that I was saying that autistic people were of lower intelligence, because that's certainly not the case.
Yeah. I don't, Cheryl, who's one of our Family Connections leaders, and was also a Samaritan in London, she said a question they would often ask was, do you want to die forever or just for a little while?
That's lovely. Yeah.
Yeah, that's a nice question.
Yeah.
And I think I you know, research can help sometimes. I have the experience of losing a friend to suicide, and one of the things that I read that really helped me with that was understanding that when someone goes into a PTSD moment, that we know from brain scans that the temporal lobe, the part of the brain that understands time, so am I in the past, am I in the present, is there a future, or am I stuck in the past, that's offline. So there's no sense of time, and that therefore the suffering that they're experiencing is eternal. If you don't have a sense of past and you don't have a sense of future, you don't have a sense of it getting better. So, you know, being aware of that and being able to help people come back into the present, and, you know, which is a mindfulness thing that you can do, and understand that if you are in an eternal suffering because you don't have a sense of past or future, then suicide might look like, you know, a valid option.
Yeah.
So helping them to be present, come back to now, and to get sight of the future is quite important.
Yeah, for sure.
Oh no. We just got a comment from a parent who had what sounds like a horrendous experience of seeing 3 out of the 4 police officers helping to get her to hospital, laughing about it. Yeah.
I'm sorry that
Deeply
experience
invalidating
happened.
experience.
Yeah.
Yeah. And that sort of callous laughing is a trauma response, actually.
Yeah.
It's because they can't deal with whatever they're facing themselves. So
Yeah.
so we need to support all our frontline workers much, much better so that they can process what they deal with every day. I don't know if we got any more questions there. Let me have a look. So I guess you kind of touched on this in the questions in the presentation, but just from a little bit more detail. If people with suicidal ideation are working in the mental health field, including suicide prevention, are there any additional signs we can look for when they potentially are presenting wellness?
Additional signs.
Like you were saying that increase of capacity for suicide is increased if you're working in the field.
Well, you've got to have awareness of that. Yeah. That
Yeah.
if you're actually working in suicide prevention, you're actually exposing yourself to the risk of an increased capability for suicide. Look, I think that those of us who work in mental health are often very good at covering up our own vicarious trauma and stress that we experience from it. And I think we could kind of rhyme off a few signs to look for that some of us might be quite adept at concealing and masking. So I guess I would just, I would think that if someone's working in that field, it's fair to make an assumption that if you're exposed to suicidal people often, most of us who are human would at times contemplate suicide ourselves.
Mm.
If we're having all these conversations with suicidal people. So I guess for me, it would be, let's just have an assumption that people who are working in the mental health field, especially suicide prevention, are going to have these challenges. Maybe just have the conversation, rather than looking for signs and not acting until we see the obvious signs, maybe just work on the assumption that it's a struggle they've got. If they're doing their job well, I would say it's very likely it's a struggle that they've got.
And does it come back to those same principles, you know, check in, are they keeping up with their friends?
Yeah.
You know, do they have that sense of belonging outside of their work?
Are they getting an outlet, like something like supervision with another professional where they can talk about their work outside their line management scenario? So they've actually got that safety valve to explode. They've got that kind of therapeutic relationship with someone who's not husband, wife, mother, father, manager, somebody who's, you know, perhaps a less prominent person in their life, but someone they can go to discuss these things. So that's the sense of belonging they've got. Maybe they should have a group of other people who work in the same field, but not in the same teams, so they can share their experiences, their thoughts and their emotions about the very difficult work they do.
Yeah.
So
I say it's a very expensive profession to be in once you pay for supervision, individual therapy, you know, ongoing professional development. But it's all necessary in order to be
just
able
a
to
peer group
do it.
thing where everyone, you know, does it for free.
That's right.
So I would say, rather than looking for the signs, which they're possibly very adept at masking, just have the assumption that they're having a struggle with it.
Yeah.
I don't know if that answers the question to the person who put it.
Yeah. So I've got a question that was sent directly to me. And if I summarize it, so this young person's been to hospital 70 times in the last 12 months with self-harm and suicidal ideation.
17 or 70?
70.
Right.
And they've got an intervention plan, which I assume is their safety plan, but is finding it hard to get consistent responses despite the plan, as everyone wants to address risk by escalating it. Any suggestion about what to include in the response plans? I mean, it's difficult to know without knowing what's in the safety plan, but there are very evidence-based ones that are, I mean, if the safety plan's been developed with the young person, it should have things on it that are meaningful to the young person, right?
Yeah, yeah. I mean, I share the concern of the person who's posed the question. If there's been 70 presentations, was it presentations or admissions?
I think
Well, anyway, in any case, it's a lot. So there certainly seems to be some inadequacies in the safety plan if there's that level of representation. And without getting too evangelical about Joiner's theory, maybe some of the wisdom from those concepts could be accommodated in the safety plan.
Yeah, so I think that the intervention, so it's not the safety plan, she's just clarified, it's the response plan by the hospital staff. And we know with BPD that hospitalisation is not ideal, like the research shows that. So I guess if they're wanting to keep So yeah, reading between the lines, it seems like the community mental health team wants to keep sending her to hospital whenever she's in crisis.
Right. Okay. So when they
And
perceive
we
the
know
risk is
that that's
high,
not great.
yeah, when they perceive
Yeah.
the risk is high, they send her to hospital, which is
Yeah.
kind of making it look like you're burdensome.
Yeah.
So I'm guessing it's the stated level of suicide risk that the clinicians and mental health team are getting concerned about repeatedly.
Yeah.
Yeah, it's a very difficult one to offer anything new on, isn't it?
I mean, I guess, yeah. So obviously, the person would be, we go to our regional hospitals and at the hospital for our region, and especially if we're part of the state services, you're going to be with the same people. In Western Australia, what does COMWA stand for? There's an organisation like it might be time to get someone to advocate
Yeah,
on their
yeah,
behalf. So
yeah.
there's
There's mental health advocacy in Australia. Yeah,
yeah. So in Western Australia, there's Carers WA that might be able to do that. There's
yeah.
also but there's what is it? COMWA, which was I can't remember what the C stands for, but it's mental health.
Okay,
It's
I'm
a
not
mental health
familiar with com.
advocacy agency. So I'm sure there are
Okay.
different ones in different states.
Yeah.
Do you want to? Bridget's got a hand up. But do you want to just pop something in the chat, Bridget, or sorry, if yeah, I think that's probably getting someone to advocate is probably it might be at that stage by now.
Sounds like the relationship may have broken down between this individual and the mental health team as well.
Yeah, I think so. I think I think we might have got so what are your recommendations, Paul, to navigate the fine line between addressing the not very helpful fear in the carers without minimizing their concern? Thanks, Bridget. And Bridget, yeah, consumers of mental health WA. That's the advocacy in WA.
Bridging, what was the two concepts? The
Yep.
fear?
In the carers without minimizing their concern.
Okay. Okay. Well, I mean, they've got valid fears, haven't they?
Yeah.
Suicide is the only cause of death that is decided on by the victim. So if they're living with that risk, it's not helpful to minimize it at all. I guess part of the question's implying that in some way the fear of the carers is unhelpful, I'm guessing. So I guess it's about situating the level of risk, isn't it? And again, I'd go back to the joiner theory. Maybe if you gave them a sense of empowerment by showing them that here's something they can do to reduce the suicidal desire of this person, do what you can to reduce their feeling like they're a burden, and do what you can to reduce their feeling of loneliness and separation and alienation. They are positive things you can do. You're right to be concerned. Here's what you can do that the suicidal person may be more receptive to than what you're currently doing.
Yeah. And I think this is also one of the skills that we teach in family connections, which is validation. So when we validate, we're not agreeing with. So if perhaps in the opinion of the healthcare worker, the young person's told them, yes, I have suicidal ideation, but my suicidal ideation is 5 out of 10, but my suicidal intent is only 1 out of 10. So they're like, you don't worry, like she's going to talk about it. Just talk to her about it. if you're going to use a DBT skill, you're going to validate. You're going to say, yes, I understand that you're afraid. Who would not be afraid of their young person dying? Of course you are afraid. And, you know, it's easy for a mistake to be made, even with a low suicidal intent. So I can understand that you are fearful. So when they're validated and they feel calmer, they will be able to hear you say, and your young person has told me that their intent is only at 1 out of 10.
Mm-hmm.
And if you can talk to them about why they're feeling so bad, what part of their life they want, you know, they feel it needs to end, then you can help them. But until we validate people, until we meet them where they are with the validation, it's hard to hear helpful advice.
Yeah, validate them, build that trust, and it might take a while until you've built that trust and mutual respect. But when you've got that mutual respect, you then earn the right to say things like, okay, you're so supportive of this person in your family. There are obviously some times where your family member doesn't find you supportive. What do you think is happening when they've got that experience?
Yeah.
And it's only through that validation and that respect they feel from you that they'll be willing to contemplate some negative aspects of their own caring.
Yeah, that's right. Or hear something.
Yeah.
Also, I mean, yeah, it's always difficult. Yeah. We've got a question about how to cope after suicide. You know, is it recommended to accept that it was the person's choice to make and find a way to forgive them?
Well, I can't pretend to have a lot of experience in helping people cope after a suicide. Most of my experience is probably personal rather than professional. Well, I guess we're talking about complex grief, aren't we? And there's a lot of counsellors and psychologists with expertise in grief. You know, complex grief as opposed to, can we call it normal grief? If Uncle Phil dies, he's 96 years old, he dies in his sleep, he's had a fulfilling life, he enjoyed good health till the end, he lived a happy life, he was a nice guy. Straightforward grieving process where everyone, you know, does whatever the rituals are in the culture. A good ritual, funeral, whatever you want to call it. And then from time to time, we feel a bit sad when we think about Uncle Phil. Normal grieving. The more complex the death, the more complex the grieving process is going to be. And it doesn't get much more complex than the suicide of a loved one, trying to work out why they decided to kill themselves. So look, I can't pretend to offer any expertise on that other than seek expert help from a grief counsellor.
Yeah. And there are, again, and I can speak to WA, there's a service called Arbor, which is specifically for people who've been bereaved by suicide. And, you know, I mean, and again, the family connections skill is, you know, any difficult situation that we're faced with that we cannot change and that we cannot change how we feel about it. The only option that we're left is acceptance, called radical because it's so difficult. And it's a practice. You know, one day you'll accept it, and in acceptance, that paves the way to forgiveness, and perhaps forgiveness of yourself, because everyone who's close to someone who's suicided will blame themselves as well, whether it's appropriate or not. That's part of the complexity. And yeah, it's a practice. You come around. One day you accept it. You might have to practice accepting it again another day. And you might have forgiven them, and then you have to practice it forgiving them again when, you know, when some consequence of their loss plays out. So yes. Yeah, okay. So we've got the somber note. but I think we may have covered off all our questions. I'll just double check. Yeah, there was a question about if someone has lost a friend or family member, is there risk of themselves dying by suicide higher? And if so, what resources or approaches may be most helpful to intervene?
Well, like, you know, we're talking about the joiner theory today. The joiner theory would postulate that, yes, that person has been exposed to suicide. That person has got an acquired capability of suicide themselves. So again, the treatment from the joiner theory would be attacking the suicidal desire, the perception that they're a burden, the feeling of being alone.
Yeah. And it is recognised that it is a greater risk. Again, Headspace has specific post-vention programs at schools. So if if a young person at a school has died, you know, they will send a team in to talk to, you know, all the other young people as well, because it is recognised that in that aftermath that there is an increased risk. So there are, you know, God forbid that it should happen in your life, but if you hear about it, you know, there are resources out there for the schools and communities and you know, sports clubs and things, that it is good to have a space for people to talk that stuff through. Okay, I think we've got we've covered all our questions, and if no one has any more questions, it's just down to me to say, you know, thank you so much for the time that you've given us today, Paul. It's been really valuable, and, you know, wonderful to have this space that we can explore it. Such a difficult, you know, and in some ways a scary topic. So, you know, thank you for making it safe for people to explore that, and hopefully they're going to come away with some useful tools and ways to think about it, and to think about parts that, you know, whilst there is a part that may be suicidal, there's going to be a part that wants to live, you know, yeah, that we can actually support people, yeah, and if you're watching this afterwards, there will be a link in the comments to donate. If you're watching it right now and you haven't donated and you'd like to donate, you can just click on that link. As we said, we have no government support, and Paul gave his time today too, so that we could share this knowledge. So really appreciate that. And if that's all, and thanks to other NEA BPD volunteers that I've seen in the chat today, and to Stan, who's our general manager, and Megan Henderson, our CEO, for being here today as well.